All right. Good afternoon, everyone. It is 12:30 Central, so we're going to get started. Welcome to the 2020 Stroke Educational Series, Field Detection of LVO. My name is Audrey, and I will be your moderator today. Feel free to ask questions throughout the presentation by typing them in the chat box on the right hand of your screen, pressing the microphone at the bottom of your screen, or if you're using phone audio, press *6 to come off mute. I will now turn it over to Deb Motes, Senior Director of Quality and Systems Improvement.
Thank you, Audrey. I have the honor and privilege to introduce our speaker today, Mohammed Taleb. Dr. Taleb is a fellowship trained in neurocritical care, stroke and vascular neurology, and endovascular surgical neuroradiology. In addition, he's the inventor of the VAN methodology. He's been a volunteer supporting the American Heart, American Stroke Association in many capacities. Dr. Taleb's advanced training has made him an expert in treating and managing disorders and diseases of the blood vessels of the brain, neck, and spinal cord. He performs minimally invasive neurointerventional procedures to diagnose and treat an array of diagnoses from ischemic stroke, aneurysms, carotid stenosis, carotid and vertebral artery dissections, brain and spinal cord blood vessel abnormalities. Dr. Taleb is a proponent for evidence-based practice, actively researching the latest breakthroughs in neurointerventional surgery and stroke. He's been involved with over 15 registries and clinical trials. The comprehensive stroke training that Dr. Taleb completed led him to develop the stroke VAN screening tool, which quickly and accurately identifies large artery occlusion. It is well known that stroke is associated with significant morbidity and mortality. Immediate identification and treatment of stroke can improve outcomes. Dr. Taleb felt that with earlier identification and treatment of patients with acute stroke symptoms, there would be an improvement in their functional outcomes following stroke. A pilot study was performed at Banner Desert Medical Center and confirmed the accuracy of VAN as an acute stroke screening tool, as well as the benefit of using VAN to identify the select group of patients, prompting immediately notification to the neurointerventional surgery team and improving the time to treatment. VAN is currently being used in other studies and being compared with other large artery tools. Dr. Taleb currently is affiliated with Banner Desert Medical Center and Banner Baywood Medical Center in Mesa, Arizona, and the Banner University Medical Center in Phoenix. I will now turn over the presentation to Dr. Mohammed Taleb.
All right. Thanks, Deb. Thanks for that intro. Yeah, I've been practicing stroke medicine for about 7 years now in basically a non-academic hospital. And yeah, we developed this tool to try to help people out. But I'm going to go over all large vessel occlusion screening tools because I think they're all very similar. And I don't think one size fits all. And I'll go over all the different positives and negatives of all of them. Before I continue, can everybody hear me clearly?
I can hear you, Dr. Taleb.
Okay, good. Excellent, thank you. So yeah, I guess we'll get started, and then hopefully we can be done within an hour, and hopefully some time for questions as well. All right. I am a consultant for Stryker, Penumbra, and Cerenovus, but this talk is not by any of these relationships. So someone asked me, so I gave this talk actually at the International Stroke Conference as an invited talk, but it was very well received, and I think this hopefully this will be beneficial for you guys as well. But anytime I think of a scale or anything I do is like, what is the goal? Is the goal catch as many LVOs or be more specific? How many comprehensive stroke centers do you have, you know? Because depending on where you are, if almost everyone is a comprehensive stroke center, you may lean towards a tool that's more sensitive and a little bit less specific. If you have very little stroke centers or comprehensive centers, maybe you want something that's more specific so you don't overwhelm the comprehensive stroke centers. Another thing to take into consideration is, depending on distance, is how fast are your transfer times as well. So I always like to begin that there's no better, there is what fits in my community needs. So review of current tools. So really how I look at it is there's quantitative, where you're adding up numbers, and you're saying, okay, if it's greater than 6, greater than 4 for the LA motor scale, greater than, for fast ED, it's 4 or greater. You're numbers and seeing how many symptoms you have and how severe the weakness is, versus qualitative. Okay, the qualitative is, are the symptoms present, yes or no? And so really Van was the first one to go towards qualitative. I can pass as well. It's more like yes, no's. Okay. And fast Van is very similar to Snow and Ventura, and all it is for vision. You have, do they have forced gaze or not? Aphasia, can they name, watch, and pen? And then do they have neglect? And that's basically it. If they have any of these basically basic symptoms with a fast exam, or fast Van positive. LVO out of Japan, very similar. Act Fast out of Australia is very similar to fast Van, but what they do is they use severe arm weakness. So you have to have severe arm weakness first. But really what it is really qualitative versus quantitative. And, you know, that's basically what these LVO scales are. And combined both of them. SAVE as well, which is looking for basically a speech, arm weakness, visual field loss, and eyes, or basically forced gaze, and you have to have all 4. So that's basically it. And so the summary of scales, all of them in general, you're looking for weakness and number of cortical symptoms. The one exception is the LA motor scale, where you're just adding up how weak they are in the face, hand, and arm. And really the question with most of these scales, which cortical symptoms are you going to test? Are you going to test 2, 3, 4? You know, that's basically it. And then how weak is weak? You know, that's basically a summary of all the scales in a gist. Another way I like to look at them is rule out LVO scales and rule in. And the problem is, and I think multiple papers, I can go through them as well, is just very hard to do both. It's very hard unless you're getting a CTA or some sort of cap that you wear in the field. It's very hard to be sensitive and specific. So how I look at it is basically Van and these other ones, the qualitative ones, they're more like NIH scale of 6. They only miss 10 to 30%. These other scales, the quantitative, or adding up numbers and having multiple symptoms, are more of a rule in, which means they miss anywhere from 20 to 65% of potential LVOs, depending on what your definition of large vessel occlusion is. Some people include M2s, some people don't. Some people include baselars, some people include proximal PCAs that are cutting off the blood supply to the thalamus, which can give you a hemiplegia with a visual field cut. So it all depends on what your definition of LVOs and how aggressive you are. It seems like we're going after more and more of these, especially with the extended time window. But really it's about what your definition is. So I like to look at them at rule out LVO scales versus rule in. This is basically most of the scales on one picture. You know, you're basically which is one branch. You're testing the frontal gaze center, which is gaze preference. You're testing ability to talk. If you have them named 2 objects, watch and pen, I usually do. Ability to understand, close eyes, make fist. Neglect, you can either look for severe neglect by holding up their left arm and telling them, whose arm is this? And they'll tell you yours, their left arm, even though it's obviously theirs. Or you can do the more sensitive way of finding neglect, which is have them close your eyes and then you touch both sides, and they tell you only right, even though you touch the left and the right. So they're neglecting the fact you're touching both sides, especially the left. And then visual field cut. And that's basically all of the symptoms that are being tested, you know. Very few scales test leg as well. Only a couple test leg. Most of them test either face or arm, and lots of them test arm or hand. And that's it. So this is RACE. So RACE tests basically face, arm, and leg, frontal gaze center, neglect, and inability to understand. They don't test visual fields back here or the ability to name objects, and it's fine. It actually works great. You have to have greater, so you add up numbers. So you have to do the face. Is it mild or moderate? Arm, is it mild, moderate, or severe? And you have to add up these numbers. Then you have to have greater than or equal to 5 in order to be race positive. All right, and they do face, arm, and leg. Then they do head or gaze deviation, so frontal gaze center. And then aphasia, they actually don't test expressive aphasia. They see if you following commands only. And then agnosia, or basically hemi-neglect, if they don't recognize they're weak or they don't recognize their impairment, which is more sensitive, more specific, but less sensitive than testing sensory neglect. LA Motor Scale, they basically say if you're really weak that you're likely having an LVO, or at least it's highly sensitive, maybe not specific. And so they're looking for face, arm, and leg, and it's 0, 1, 0, 1, 2, 0, 1, 2. And basically you have to have a number of 4 or greater. So I like this picture because this shows you what's really cool is, they're technically absolutely correct. And I think this is a good way to do it as well, is they're saying, well, most people that are very weak, you see this in dark black? Sorry, I'm going to go back. Right here, most people with large vessel occlusion do have severe weakness, right? But not vice versa. Look at all these patients with large vessel occlusions with NIHO scales of like 5, 6, 7, 8, 9, 10. Look at all this. So close to half of LVOs had an NIHO scale less than 10. Okay. The question is, will these people go into collateral failure or not? That is, that's a question that we're still looking into and we're doing some trials on. But the point of the matter is that's how you get away with severity only, because most severe strokes are LVOs, but not vice versa. I think this is the Cincinnati Pre-Hospital Stroke Severity Scale, ability to talk, ability to understand. They have you follow commands, frontal gaze, and then they test arm weakness. Very similar as well, you're adding numbers. Fast ED, it's very similar to race. The only difference is they don't test leg, okay? And they do have you speech changes here. It's not spelled out, but they do actually have you named 3 objects in addition, so they don't just test expressive, they also test receptive aphasia. It's similar to Van, more of a complete cortical symptom testing. PASS is very similar. These are areas of the brain it tests. They have you correct age and month, yes or no, your gaze, and then arm weakness. And you can see arm weakness is a recurrent theme in almost all of them, because arm weakness is the best predictor out of motor, face, arm, and leg. Arm weakness is the best predictor of LVO. It's the most specific for large vessel occlusion. And that's why you see all these scales over and over and over again. Arm weakness, arm weakness, arm weakness. Out of Australia, you have to have severe arm weakness. LA Motor Scale, you have to have arm or hand weakness because you don't have enough points to even be LA Motor Scale positive without arm weakness, right? And even this, if you think about it, I haven't seen someone with an aphasia can't talk with forced gaze with 0 arm weakness. So in a sense, even this has to have arm weakness. I mean, I've looked at 3,000 patients and I think only something like 2 or 3% where they had forced gaze and inability to talk with 0 arm weakness. So you see this recurrent theme over and over and over again. What? Arm weakness with a cortical symptom. And I had given a talk, race versus Van, at one of the conferences. And again, it's all about, do you want to catch more or do you want to be more specific? And so this is the screening tool that we use not currently. I did this because it was a little bit easier. I moved forced gaze from neglect over to vision. And the reason why I did that is because then it's a lot easier. You know that aphasia is with right-sided weakness and neglect is with left-sided weakness. And basically all you do is you test for arm weakness. If they have no weakness, you're done. They're Van negative, 2 seconds. If they have any uneven arm weakness, either the right or left, then vision, you test for forced gaze, Visual field, you hold up 2 fingers on the right, 1 on the left to make sure they can see both sides, or where the vision loss is. And then naming for the aphasia, watch pen, and then basically for following commands, close eyes, make fist. And you, to be VAN positive, you just need arm weakness with any of these. If you have no arm weakness, you're VAN negative, even if you have a cortical symptom. And if you have no cortical symptoms, despite how weak you are, then you're VAN negative. In Canada, they do fast VAN, where they only test gaze and naming. They don't test the ability to follow commands or vision loss. And if people want to do that, that's fine too. As long as you're testing something in vision, either gaze or vision loss, something in aphasia and neglect. And this is very similar to Pomona or Snow or Ventura scale. The reason why I show you guys this is to show you that they're all very similar. So this is a study out of Switzerland, which basically NIH and looked at all the different scales. Again, they're very aggressive. Dr. Fisher's group, they tend to be more aggressive. They call any M2s or dominant M3s LVOs. And so, you know, they said if you use race or 3-item severity scale, you'd miss anywhere from 75, 50%. Cincinnati would miss 50%. But again, their definition of LVO is, for that time, 2016 was aggressive. Now, I think in 2020, we are being a little bit more aggressive. There are some trials going on, so we'll see. Maybe that definition was correct, not just a proximal M1 in an ICA. And what they did is they basically showed what are the odds ratios out of the NIH stroke scale, what are the best things? And you can see here, the odds ratio, the best things are basically the VAN exam, motor arm, not leg, not face. And I think this was with about 1,200 patients, close to 1,269 or something like that. But over 1,000 patients. Gaze, of course, motor arm weakness, aphasia and neglect were almost the same. And then visual field. And this is basically the VAN exam. And anyone who's practiced neuroscience medicine, whether nurses in the neuro ICU and the ED, whether it's neuroreds, stroke neurologists, neuro radiologists, we know this to be true. If you're able to do a good exam and you know the definition of aphasia and neglect and visual fields, and you can do a good exam, we know this picks up the most amount of LVOs. And so this was not surprising. This is another scale, sorry, another study. This was an interesting one because here they looked at actually, they said if you have old strokes or leukoariosis, which scales are better, and they showed ones that use severity are better. And it makes sense because if you have an old stroke and some minor weakness, if you're looking at qualitative, you're still going to pick those up, right? But if you're looking at a quantitative where you have to have severe weakness, you're more accurate. But again, the interesting thing is, look at how many LVOs, vertebral basilar, ICA, M1, M2s. Look at this, NIH stroke scale 0 to 5 and up to 10, you know, close to half of it. So this was very interesting. And here you look at the sensitivity. You know, if you use race, their sensitivity is about 50%, so you're missing 50. But they're more specific. You see that? So it's very hard to do both. The VAN, as you see, was the most sensitive, picking up 70%, but it's less specific. Again, it's all about, but the positive predictive value for VAN is about 28 or 30%, very similar to Cincinnati and 3-item stroke severity scale, right? Whereas in FAST-ED is 35% and race is about 40%. So you lose about 10 to 12% in the positive predictive value, right? So the point is, what's that saying? You can't have your cake and eat it too. Any questions about this? Or about this concept of you can't be both sensitive and specific? Okay, I'll just wait for questions then. And this is very interesting to do. So if you look at the curve, all subjects, you can see race, FAST-ED, and VAN. They're all very similar. but the difference is one is more sensitive and one is more specific. And this is any LVO. This is if you just say IC and MC and M1. And if you look at all LVOs, you see how the curves are very similar. I just think that's kind of cool. That it just shows you that the area under the curve is very similar. This is just one study. So then why was the Switzerland trial, why did it show those VAN features are the best predictors? I think it's all about the definition, right? And in this you can see, if you define it as just M1s or MCAs, the area under the curve goes down, but then it goes up if you define more are considered LVOs, you know? So if you include M2s, M3s, Baselers, P1s, I think it makes a difference as well. So to me, accuracy is really in between prevalence, right? Accuracy, and no tool has it all. If your prevalence, meaning you only have 5% that are LVOs, then you want the more sensitive tool like RACE or FastED. If your prevalence is close to 30 to 40 or 50%, you want a more specific tool, whatever it be, like ACT Fast, VAN, Fast VAN, Pomona scale, all these ones that are more that are more sensitive. Sorry, if you have 40%, you want the more sensitive because that'll influence your accuracy more. This is a Penn State study. Again, they took about 973 patients or 1,000 patients. This was also at the International Stroke Conference. And they basically said, same thing, that basically VAN identified the most, but was the least specific. And we had to see how it does in the field. You know, and here it is, 89% versus 72. This is for how sensitive it is, specificity, 74 versus 89, 86, you know, and then accuracy 66, but 59, 74, 70, 72, depends what you want. And then this is the positive predictive value. Negative predictive value was 94% versus 90, 91. And so you can see all of them work similarly. The difference is, do you want to pick up more LVOs or not? And also, you may over triage if you're too sensitive as well. So maybe you don't want to over triage, you know? And so this is very important as well. This was our study that we did, and I think they just published the one from San Antonio as well in Journal of Neurointerventional Surgery. But basically, we showed that using VAN in the field was very similar to the NIHO scale of 6. Okay, it basically accuracy was about 60%, 66% or so, specific 65 versus 60, and positive predictive value was around 30 to 32%. Now we'll talk about ways to be more specific in a second here, but the point of the map does work like the guidelines, which are you should be screening patients greater than NIHO scale of 6 or greater with a CTA for an LVO occlusion, and that's basically how it works. They're like, okay, fine, but who cares about that 20 to the LVOs that with NIHO scale between 0 to 10? We just want ones greater than 10. The problem is arm weakness, minor arm weakness with expressive aphasia. Is aphasia not a disabling stroke? Is not vision loss? I mean, these are questions we have to answer. And these are patients with low NIH, actually 5 or less, that went into collateral failure, and about 41% went into collateral failure. So these patients can get worse. So identifying them at some time is important. There's other things we can do. The problem is, so I used to say, well, as long as they get a CT at a primary stroke center, but 20% of LVOs can be missed on imaging. This is the VAN tool that I have, which you can download. If you just look it on Google Play or on the Apple Store, you can download this and you can just put in the symptoms that'll tell you where the clot is. Here it says superior M2. One came in, had aphasia with weakness, but they were following commands, no vision loss, no neglect. So I put it in and it said that it's the superior M2, and that's exactly where it was. There was a superior M2. Again, it's a dominant division, very disabling stroke. So yeah, being able to identify some of these may help patients out. Here's another one. This is an inferior M2. And again, these are rare, but it's important to mention them again. They were all negative, VAN positive. Here's the clot, recanalization. Patient is able to see and move again. It was minor neglect and a visual field cut with some minor arm weakness. You know, and the question is, are we looking for severity or are we looking for type of stroke? This is another paper, I believe this is out of Switzerland as well. The problem is if we're going out between 6 to 24 hours, you see LVOs because the collaterals or number of the penumbra is bigger or there's better collaterals. People that present between 6 to 24 hours, their NIH stroke scales are actually low. So if you take the sensitivity specificity curves, your average NIH stroke scale is 4. And so if you're going to be screening people between 3 to 6 hours as well, it's 7. And then 6 to 24 hours, the LVOs, because the collaterals are so good, they have some symptoms, but they're not that bad. Their brain is dying very slowly. And so you see this sensitivity time delay, 6 to 24 hours. The average NIH stroke scale is actually low. So using a severity scale between 0 to 3 hours, like someone that's very severely weak, is fine. But if we're going to be doing LVOs and catching these late patients, it's going to have to be a type of stroke scale, not just a severity scale, honestly. And I'm not sure if we should be doing this in the field or in hospitals. Anyway. For posterior circulation, we know baselers and PCAs can present with low NIH, and it really doesn't matter when you present. And the question is, should we be going after these baselers? People say yes. P1s that affect the thalamus, it depends. I've heard people go both ways. All right. This is another one, same thing. Basically saying Van scale was consistent with LVOs in about 68% of patients. But here it's saying that despite how sensitive it is, it only caught 70%, meaning there are people with no arm weakness whatsoever, which, you know, that basically had an LVO. So I thought this was interesting as well. This is the same thing saying that depending on how sensitive or specific you are, in 0 to 6 hours, and then in 6 to 24 hours, again, Van, CStat, MAPS, they were the most sensitive, both from 0 to 6 and 6 to 24 hours. This was about 750 patients as well. So this is a summary of everything. To me, if any scale, you should at least test arm weakness, honestly, and you should test something under vision, either gaze or visual field. You need to test aphasia and neglect, you know, and I try to test all of this, any weakness with cortical symptom, but you see that all the scales are the same, right? And my goal is really for everyone to be speaking that language. Hey, they have minor arm weakness or severe weakness with cortical symptoms. Hey, their eyes are forced over, or they can't talk, or they're ignoring the left body. They're neglecting the left body. I think that's very powerful if we can communicate that way, as opposed to an arbitrary number. Hey, they're race 7. You know, what does that mean? You know? And these are the qualitative scales as well. Same thing. We're all testing the same thing. This is just showing you at the map. The more you test, the more sensitive you are. The least you test, the least specific. And the LA motor scale is right in the middle. Summary of all scales. You basically add up numbers. How weak are they, and which cortical symptoms do they have? This is a study that we did in Phoenix, and I thought this was important because these are patients NIH stroke scale 6 or greater, and are we screening for them? Again, this was in 2016. I presented in 2017, 2018. Yeah, and I think I presented in 2017, end of 2017, but the data was from 2016. But the point of the matter is, we were not screening people, and then even the ones that had NIH stroke scale greater than 6, is about 40% were not screened. That means only 40% were screened. 60% of patients that should have been screened weren't. And the transfer times, 15% were done within 2 hours. That means 85% took greater than 2 hours. So again, nothing in the field. You have hemorrhagic strokes, you have seizures, you have subarachnoid hemorrhage, you have toxic metabolic symptoms. And when we look at studies, see were they field studies taking everything out, or were they just stroke patients only? And so that's important. I think the future is going to be mobile stroke units. I think it's going to be apps. I think another way to improve is basically looking, this is important because what ACT Fast did, they took severe weakness, severe arm weakness, but they also had mimic questions like the Rogier scale. And so ways to improve specificity is basically you can use severe arm weakness. You're like they're Van positive with severe arm weakness, bypass. You know, you can use mimic questions. And I think that's important. You can only bypass 6 hours because after 6 hours, yes, we can help you between 6 to 24 hours, but that percentage is way less. It may be only 10% or 20%. If you're an LVO between 0 to 6 hours, we may be able to help out 40 to 50%. So maybe only bypassing people up to 6 hours, you know? And so these are things we started to do in the field. You know, these are proposed things. A stroke mimic questions, boom, 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 boom. TPA criteria as well, and then consider endovascular bypass criteria. Less than 6 hours, new deficit to make sure that these aren't old deficits, living independently, because if someone is bedbound at home, I don't know if you should bypass these people. And then pass the stroke mimic questions, very important. And then has severe arm weakness in addition to the Van symptoms where the arm just you know, again, these are ways to become specific in the field. And then anyone who has weakness with the cortical symptom, you can still test them, but maybe bypassing only for severe weakness. They pass all the stroke mimic questions. They were living independently. So your positive predictive value goes up. Again, I would only propose this if we're still identifying them in the primary stroke centers and we're getting CTAs on most of these patients. So what is goal of bypass? You know, this is important. You know, I think there's a lot of things that we deal with that are not LVOs, whether it's getting TPA to non-LVOs, whether it's getting an EVD in or mannitol for mass effects for subdural, subarachnoids, ICHs, tumors. There's lots of other things when we're considering bypass. Maybe the future, honestly, maybe TCDs, right? EEGs, VIPs, where you put these caps on people, and then, you know, there's other devices that are coming out as well. And I think maybe that's the future. So maybe it's a moot point. I believe technology will make this go away, but I still do believe understanding neuroanatomy will always be helpful. And you can go to my website, www.strokevan.com, and you can actually get certified. And there's an even better lecture which goes over neuroanatomy. And I do have that lecture. So depending on time, I may go through that as well. All right. I'm just going to open up the chat and start to answer some of these questions. And then I'll go to that to that other lecture. Okay. I just lost sound. Can you hear me now?
Yeah, we can. Yes, we can hear you.
Okay.
So we do have several questions in the chat log.
Yeah, I love the explanation of them.
Okay, so
let's scroll down.
Yeah, I can read them out. Do you think the variability we see in LVO scales reflect the anatomy and collateral circulation support downstream function?
Yeah, I definitely think that sometimes you miss stuff because the collaterals are so good. There's actually something called a LVO mimic, which basically a lacunar mimic. So it looks like a lacunar stroke because the clot is right in the M1, but the patient has no cortical symptoms. they're only getting the tiny lenticular striate arteries to the internal capsule. And I'll show you in a little bit. You're basically getting a small vessel disease from an LVO, right? And so some of those can be missed where you have weakness only without a cortical symptom. But that is only present, where you have that, it's only present in about 10 to 20%. 80 to 90% of the time you will have a large cortical symptom. So yes, collaterals can make different scales look different depending on the patient.
Okay. What are your thoughts on ASLS for better assessment pre-hospital?
Sorry, I don't understand that. Sorry.
Okay, Craig, you can star 6 to unmute if you'd like, or anybody to ask the question.
Hi, sorry about that. Advanced Stroke Life Support uses the MEND exam. They've got both a large vessel and a fairly in-depth regular assessment for pre-hospital. I wasn't sure if you were familiar with it or not, but I didn't see it listed in your scale. So just curious if you had thoughts about that.
Yeah, I think any scale that that looks for cortical symptoms and can distinguish LVO versus not, or cortical symptoms versus not, is helpful. And I know that the MEND exam is very good. I mean, that's basically what we try to do with FAST-VAN. FAST identifies all stroke, and VAN is supposed to, with weakness, identify like an LVO. MEND also asks for other things. I do believe. I'd have to pull it up, but I want to say they measure blood pressure as well. Is that correct? And they look at stroke mimic questions.
They do look at stroke mimic questions. I know blood pressure is part of the assessment that they're teaching. They start off with FAST, and then there are 6 different additional things. About half of those are LVO.
Yep.
As a follow-up for this too, while you're thinking about it, we've got all these people on the inside. That one of the more difficult courses is the admitted patient who comes in with a stroke that we don't catch on the way in. Is there a recommended either VAN or something, and at what sort of clock are you looking at? 24 hours or shorter?
For inpatient, honestly, I would use the most sensitive, and VAN is the most sensitive, and it works very similar to the NHO scale of 6. I mean, there's been at least 4 or 5 studies that have shown that. And so if you're going to use something on the inpatient where you want to be as most sensitive as possible on the inpatient, I'd probably use that. And I know UT Houston is using it for their greater than 6 hours to activate a stroke alert. But for outpatient, that's a different story. I mean, different people have different opinions about whether they want to be more sensitive or specific.
Okay, another question. My understanding is there are devices that are being studied for use in pre-hospital setting known as VIP, volume impedance phase shift spectroscopy, that EMS can place on a patient's head and used to detect LVO in the field. A 2017 study from the Journal of Neurointerventional Surgery showed a sensitivity of 93% and specificity of 92%. I was wondering what you make of these sorts of devices for LVO detection.
Yeah, so again, I definitely think they're good. I think right here, sorry. I think if you go back here, I put it on here, VIPs right here. So yeah, I actually have an entire talk just about all of these devices. So I think that's where the future is going to go. The problem is, are they going to be able to pick up PCA strokes, basilers, dominant M2s? That I don't know, because most of these studies are looking at M1s and ICAs. And again, maybe that'll pick up about 60 to 70%, and maybe that's all we need. But in general, I think, just knowing what cortical symptoms are, knowing what an LVO means will also be helpful. But I do think the future will be some of these devices for sure, because again, it's very hard for a scale to be sensitive and specific.
Okay. How many LVOs are missed when there's no arm weakness, but a critical sign is still present?
So so that's a good question. Depending on which study you look at, it's anywhere from 10% to 30%. And this is based off of, I think I looked at least 7 or 8 studies. So there are some people, but most of the time these are LVOs that are non-dominant M2s that TPA works for, honestly. It's very rare where you have zero arm weakness and you have a proximal LVO. That is very rare. I would say that's less than 10%.
Okay. Another question, how long will the collateral circulation support that issue before they fail?
Depending on which study you look at, some people go into collateral failure 6 hours, 12 hours, 24, 48 hours. There's, and it depends. There's just a paper that just came out in JAMA Neurology. I think it just came out like yesterday or 2 days ago, or at least that's when I saw the tweet anyway. But they were actually doing thrombectomies up to 10 days. And so the collateral failure can happen at any time, but I would say most collateral failure happens within the first 24 to 48 hours.
Okay, and the last question in the chat box, but if anybody else has a question, *6 to unmute yourself. So how would you best argue the use of VAN to an existing EMS system that is hesitant to use any LVO screen because none of them are 100% and the literature is still young?
That's a good question. I mean, I would argue, depending on where you are, you know, honestly, when I made VAN, all I wanted people to realize was its arm weakness and what cortical symptoms are. But if you're somewhere where there aren't lots of comprehensive stroke centers and you would overwhelm the system with lots of LVOs, I'd probably do it, but I'd use something like this. I'd use stroke mimics, endovascular bypass criteria, and this will help your specificity, so it'll be more specific and you won't over triage that much. But the fact of the matter is lots of these have been tested in the field. I mean, even VAN has been tested in the field both in Phoenix and in San Antonio, and I think they're starting to do it in Louisiana now as well. And there's lots of others. LA Motor Scale has been tested in the field, RACE, tons of testing on RACE in the field as well. And again, they're all testing the same symptoms, weakness with a cortical symptom. So I think it's very hard to argue that weakness or severe weakness with a cortical symptom is not a good way to identify LVOs. Another argument is if it is a brain bleed or a tumor or seizure, all of those need to go to centers that have neurosurgery anyway. And, most primary stroke centers are not trauma plus comprehensive plus primary stroke centers where they have neurosurgery and neurology 24/7. So most patients are going to end up going to a comprehensive stroke center anyway.
Okay. And we have another question. We are currently using MINS. Would you recommend that we switch over to VAN given increased sensitivity? We have one comprehensive and one primary stroke center in our region.
That's a good question. You know what? Honestly, if MEND is working well and you're able to identify LVOs versus not with it, I think it's fine. I mean, honestly, if as long as people are using something, I think it's fine. If you want to locally do VAN when the people get to the hospital for nursing to see how many they're catching that the MEND may have been missing, that's fine too because it's more sensitive. But for a bypass, as long as you're using something, I'm not attached to anything. I realize that everything has its positives and negatives. So as long as you guys are doing something and you're trying to identify LVOs, I'm honestly, I realize that there's positives and negatives to everything.
Okay, thank you. Anybody else have a question that they want to ask? *6 unmute okay, so where do we find the recorded version of this? We actually will send a link to the recording along with a certificate of completion within a couple weeks of the end of this seminar. Okay, I'm going to hand it back to you, Dr. Tillett.
All right. So I'm just going to go over this quickly, and this is one of the talks I give to some of the EMS. It's very similar, but it goes into why we're doing VAN. But I figured if you guys are on here, you know what LVOs are. You know that it doubles the people that are functional. You've probably seen some of these scales. You know how number needed to treat versus PCI. We can go out to 24 hours. You know how we need a paradigm shift from thinking from MI, EKG, non-ST elevation MI, medical treatment, ST elevation MI, cath lab, stroke, LVO versus non-LVO, and non-LVO we give TPA, LVO we give both. And so I just wanted to, you know, this is what, if you go online, these are the slides that you'll see for the VAN certification. And I just wanted to show you, even if you're not bypassing, this is a study that was done here in Phoenix where they actually reduced the door to TPA by doing VAN in the field because they knew this was for sure a stroke. Because if you're thinking LVO, you know it's ischemic most of the time if there's no bleed. And so they actually reduced their TPA time from 56 to 35. But even if you're not bypassing, they reduced the transfer times by identifying these patients early. So I wanted to point that out. Even if you're not going to bypass, still do LVO screening in the field because it'll allow the system to work much faster, right? It'll allow the CTA to get done faster, allow the transfer center to be called faster, the helicopter to be done faster. So even if you're in a rural area with no comprehensive stroke centers, screen. So when they come in, everyone is like, okay, I have to think about transfer room right away. I need the helicopter right away. And that I just wanted to show you, just because, you know, I'm not saying we have to bypass in the field. Even if you don't, there is another reason to move things faster and to reduce time to definitive endovascular treatment is another reason to be doing this. And then this I just wanted to show you guys in case you haven't seen this. This is all online as well on the VAN thing, but I wanted to show you this. The reason why, you know, face, arm, and leg weakness, you know, you can have that is because you see all this face, arm, and leg, they all come down to something called the corticospinal tract, which is as big as basically a penny, okay? It's super small. See that? And that goes all the way down to your spinal cord. So your face, arm, and leg are super weak. That doesn't necessarily mean all of your brain on the side is not working. All that means is that that tiny tract that goes to the spinal cord is out, you know? And basically, VAN is nothing more than these cortical symptoms. So all strokes, small vessel, lacunar, have pure motor, pure sensory, or motor sensory, and dysarthria, which is slurring of speech. Okay. Now this I want to point out because this is a tip that I wanted to let people know. There's basically two tips that I want you guys to know. Is slurring of speech. Just because you're talking like this, it doesn't mean you're aphasic. That just means you have weakness, or you're drunk, or your glucose is really high or really low, right? Or you're doing drugs, or you have an infection, toxic metabolic encephalopathy. So that I wanted you guys to know. Dysarthria or slurring is not aphasia. Aphasia is when you actually can't name watch. Like if someone shows you a watch, you're like, you know, or pen, and you just can't say anything, or you can't follow commands. And so I just wanted to give you that tip in case people are using VANs. And word on stroke mimics and arm testing. Stroke mimics like sepsis, low glucose, seizures, hyponatremia, brain tumors, especially global weakness, they usually both arms are super weak. And that's why it's very important. Unilateral arm weakness, or one arm is weaker than other, okay? This is a tip that I give the EMS when I'm doing the VAN training, okay? So that's super important, you know? you know, and I think I went through this as well. So basically, just in case you guys haven't done this, all we do is we test arm weakness. If there's no uneven arm weakness, you're done. If there's uneven arm weakness, we basically test for vision, forced gaze, or basically visual field test. And one very important thing, and I know that you guys can't see the video, but if you want to write this down, is you gaze away from the side of weakness, meaning you can't bear to look at your weakness. So the gaze is the strong side, your eyes are forced towards your good side, and your vision is intact on the good side, and you have vision loss on your bad side. That means you can't bear or see that you're weak on one side. And that's a way to actually tell a seizure versus a stroke. And I figured I'd just let you know that. So for vision, both fourth gaze and the field cut are towards the weak side. So I think that's really cool. Your eyes look towards your strong side because you want to see your strong side, and your vision is maintained on your strong side, but your vision loss is on your weak side. Okay, so that's another thing for, naming, watch, pen, close eyes, make fists. This is all straightforward. And then for neglect, another tip is make sure they close your eyes and touch the right arm, then left arm. Make sure they can feel both, and then touch both at the same time. Okay, to make sure that it's not sensory loss and it's actually neglect. And I think that's it. And I think you guys are boring. No arm weakness, you're Van negative. Arm weakness with normal vision, aphasia, neglect, you're still Van negative. Van positive, you need uneven arm weakness with a Van symptom. This is another form I have. This is in case people don't want to test vision loss and following commands. At least do the forced gaze, can't name, or ignoring left body. So I call this the Van fast Van. At least do everything in red. If you're getting lazy. And I think that's it. And I have some case presentations as well, but I think you guys are pretty good. Slurred speech is not aphasia. I think we beat that to death. Patient can't talk with weakness. And I think that's it. Thank you.
All right. I see one more question here in the chat box, and if you're 2 hours, if you're 2 hours from Comprehensive Stroke Center, don't you want to go to the nearest TPA-ready hospital to get TPA on board?
Yes, I agree. If you're over an hour, I definitely should go to the nearest primary stroke center. But I still think you should screen in the field, because if you're telling them, hey, yes, give TPA, but we think this is an LVO, at least they can start calling the helicopter. They can do CT, CTA first, because some centers still do CT. They give TPA, then they send them back for CTA. But if you make it a parallel process where you make all the decisions up front, even if you're taking them to a primary stroke center, I agree. If they're over an hour away, you need to go to the nearest stroke center.
Okay, thank you. Are there any further questions? I'm not seeing any. So thank you so much, Dr. Tello. That was a great presentation. We've had some great questions. And you will get, like I said, a copy of the slides and the follow-up once we, within a couple of weeks. So I'm going to turn it back over to Audrey to close us out.
Thank you, everyone who joined today, and for Dr. Taleb for presenting. If you have any questions, don't hesitate to reach out to us. Thanks, and have a great day.
Thank you, guys. Bye.